Thank you everyone for having come along for this meeting, and I thank Reverse Rett for inviting me to speak here. As everyone would know, I have a special interest in individuals with disability in general, but especially with rare diseases, because one of the issues with rare diseases is that it's usually chronic and it spans multiple specialties, and trying to actually coordinate care is very difficult. And parents take on the responsibility of trying to coordinate care. And coordinating care in rare diseases is it's almost a full-time job, because you do not have the sort of support that's needed, and often you go to appointments and you end up realizing that you probably know more than the person you're talking to about the condition your child's got, and yet you have to continue with the process. And so that really spurred the interest in terms of trying to work in this particular area. And we were very fortunate for that Reverse Rett, especially Rachel and John and team, actually funded the original aspects of the center, and that's how the CIPP Rett Centre was started. So I'm going to be speaking about autonomic dysregulation. I'm not going to claim that I'm the expert in this, but I think there are quite a few things to be understood. Some very basic issues, some of the emerging things coming through, which may be of use to consider in the longer term. And let's move. So these are conflicts of interest. So I lead the team. As already John said, I am the CEO of Health Tracker, where we created the platform. I've worked on many clinical trials. And the way the center has been set up is that I've got a clinical arm where it is the clinic sits in the Maudsley Hospital. We also provide the neuropsychiatric services for the Tadbert Children's Trust, where it's acquired brain injury. Then at Great Ormond Street, we continue to have links and provide support for metabolic disorders. And then when clinical trials are done, we do that in King's College Hospital at the moment. And my academic relationship is in King's, and I also am an honorary professor in Dublin. And in terms of the clinical trial facility, we use the facilities that are available in wherever the trial is being done. And of course, Reverse Rett has been a huge part of the service as such, in terms of supporting it. And there are some changes that are happening, which I'll just highlight. And of course, Health Tracker has allowed us to develop things that would help this population. So one of this is a slide that we only just shows the pathway of the kind of patients we see in the clinic. And this is the first stream as such is basically all of the kids we now see have rare diseases. The first stream are children who have rare psychiatric disorders. So these are children with catatonia, childhood psychosis, and so on, who are very, very rare. Those conditions are not common. They're common in adults, but not in children. So that stream of children, so we have children who are coming to us with psychosis at the age of 6 and 7, but they may actually have another condition in the brain which probably has been missed. And so that stream of patients, we continue to see them. And so the trust has just agreed that we can continue to see them till 18 years, those who have a psychiatric illness, and then they move on to adult services. But then we've got the group of rare diseases, which is to do with the non-Rett rare disease group. We've got permission to continue to see them till 25 years of age. From 18 to 25, we are trying to work with adult services to try and train them to be able to take on the care as they move along. Because one of the problems is in adult services, as Dr. Lumsden already stated, the state of care in adult services for rare diseases is limited in terms of a holistic approach, especially when it comes to multi-system coordination. And then, of course, more recently, we've ended up having increasing number of patients being referred to us who have undergone transformative therapies. So these are patients who've either had gene therapies for different conditions, often for leukemia and other things, and then they've ended up with a psychiatric condition, and then they need to be started on medication, and not all psychiatric medication can be used in those individuals because you may inadvertently re-trigger the original problem. And so therefore, those patients have started coming into our clinic, and some patients were after transplants, so after cardiac transplants and so on and so forth. So increasingly, that's a stream of patients that we are ending up having to see, and so we've ended up starting to manage their care, and we continue to see them till 25 years of age, whilst trying to train adult services to take them on. And of course, then comes the large group of patients with Rett syndrome, whom we've got permission to continue to see them lifelong. And that is across the lifespan. And I think our oldest patient is around 60 or 61 in the clinic. And so that's one of the issues that we've actually managed to get through the NHS route, so that we can actually see those patients across the lifespan, co-working with adult services, who are more than happy for us to continue to hold the specialist care while they will provide the other aspects of things. So it's the clinic as such. So the previously the referral was to the center, was even a self-referral was sufficient. Organizations could refer them and so on. However, with things changing, we now require either a pediatrician or a consultant to make the referral to the team for the patient to be seen in the clinic, because the NHS funding comes only in that with that happening. So that's really the significant shift which is slowly starting to take place. And we do not claim to have expertise in all areas. We don't. We focus mainly on the emotional, behavioral, and autonomic dysregulation component. But what we have recognized, having looked through patients and looking through how we've managed care and who've benefited from our care, there's one striking thing that's come to fore, and that's to do with the fact that there's better concordance in thinking and understanding of what the problems are by the clinician involved, by the patient and the family, and also the system. And I think the system is a significant component where we've ended up having to spend a lot of time trying to work with the system, who may be an adult physician whose views on Rett syndrome may be very different. And as Dr. Lumsden said, part of the issue is actually being able to educate and understand, get people to understand. So we've now, increasingly, we are traveling around the country. In some of the time, patients are in intensive care, and we are trying to train and teach the clinicians there as to why something may be related to Rett syndrome or not. Because without that, the kind of interventions being provided may not be the most effective. So in a sense, this, even though we talk about medication and treatments and so on, a lot of it revolves around being able to improve the understanding, and we've ended up calling it concordance in terms of diagnostic understanding, concordance in terms of what needs to be done, and concordance in terms of how the pathways should be actually managed. And unless we actually get that done in a coordinated manner, we are not going to get the desired outcome. And especially if we want the patients not to lose skills across time, not during the initial regression phase, and to actually gain skills that are needed, that is possible, as Dr. Lumsden was stating. So how do we go about it? This is a slide I've presented many times. When a patient is referred to us, we collect the information using questionnaires and so on, using the health tracker. We get variable-based data so that we get the physiology, which is how we can actually look at some of the issues around sleep, autonomic function, movement, and so on. And then, of course, we use the data and try and analyze the data to understand what we can learn from it, and how we can actually improve the care. And we more or less every 6 months, we're looking at data that we've got and learning from that to try and see whether we can improve what we do and provide for patients. So this is a complex slide, but it's understanding that when it comes to multimorbidity and rare diseases, we should not be focusing just on the genetic mutation or a metabolic problem. We really have to look at it at the whole system, that is to do a biopsychosocial-ecological lens. If you're looking at biological factors, yes, we have genetics, and one of the things that even though the criteria for typical Rett and atypical Rett talks about the first 6 months having to be normal as such, often what's missed is the fact that some of the children could have actually had a difficult birth, and you've got hypoxia on top of that. So you've got a double whammy where you've got hypoxic brain injury, which is mild, and on top of that, you've got a genetic condition that's actually emerging. And the two together may actually be more than the sum in terms of the outcome. So that part of it is, so those are all the aspects that have to be looked at in terms of biological stuff. And when it comes to psychological factors, in terms of early life experience, there's a lot of issues in terms of being able to manage the complexity of care, stress within the family, and so on and so forth. In terms of social factors, there can be in terms of secondary to disability, there can be discrimination, bullying, and other things. And of course, the ecological factors, that we have ended up starting to recognize is a crucial aspect in terms of managing care. And this is often not to do with the individual, it's to do with the system they're in. Trying to navigate someone's medical care across transitioning, whether it's to do it from after 18 or not. You've got legal issues that you have to deal with. You have got systems to deal with in terms of adult services. You've got someone who's an endocrinologist. You've moved from a child endocrinologist to an adult endocrinologist with no understanding in terms of how to coordinate the rest of the care which is to be done. And a lot of the time it's to do with managing those systems which are outside the child in order to be able to get the optimal functioning of the care and the outcome as such. And that's what we've ended up coining as a concordance approach in terms of the systems itself at the systems level. And this just to say how the health tracker thing, and there's a website and also an app that's going to start in a month's time or so. In terms of what do we look at, even though we are focusing on emotional, behavioral, and autonomic dysregulation aspects and sleep and so on, the thing is that when they are seen in the clinic, we do get the history across all of these areas that are described here, just for the purposes of actually documentation and being able to understand what is it that we have to do and how do we actually have to coordinate with the other specialists in the area. So, for example, if someone's got epilepsy or dystonia and is under the care in another service, it's what we end up doing is trying to coordinate, link up with the other service, understand what is needed, and try and develop a more coordinated approach. So the ones in blue, which is to the emotional dysregulation, the behavioral dysregulation, and the autonomic dysregulation, are the areas that we focus on. The rest of the information, what we're doing is we're basically collecting the medical information and we're repackaging the information in a manner that the family can use when they go to the respective specialists for help. Because it's one of the things that we've found repeatedly in the clinic is that the families have gone with a lot of difficulty, they've managed to get to the right specialist. Unfortunately, when they're there, they're talking about everything else but what is needed and relevant for that specialist to understand, because what is relevant to that specialist is actually camouflaged by all sorts of other things that have been discussed with that person. So what we end up doing in the clinic is we repackage the medical information, all of the information that we get, and we explain to the family that if you're going to X, then please focus on this area first and then talk about the other things, so that you actually end up having a better, fruitful outcome when you actually go to the right specialist, which has taken a long time for you to get to. And when looking through the records, this particular aspect is just as important as the concordance, apart from all of the other things that we do, including providing support and everything. So what I would say that is different in terms of what I would typically do in my clinic is that we specifically look at medical information, help repackage it in a manner to make it more sensible, and then actually give it back to the family to actually take it to the relevant clinicians, and we try and coordinate and assist in that process. And in our experience, that has made huge positive impact, because the clinicians themselves have called back and told us that it's made a big difference to them, because for the first time they've been able to understand what the context of problems are. Because a lot of the time they end up thinking, the people who they go to end up thinking that it may be all related to just Rett syndrome. And of course, the other aspect of it is to do with medication side effects. And as Dr. Lumsden said, even when we are talking about long QT, someone's already having mild features. They're already around 460, 480 milliseconds, and then they end up with an infection. They go and they're put onto an antibiotic. That might actually increase the QT interval significantly without them having recognized the person is already at risk. And so it's those kind of things that we end up trying to highlight and provide it as something that the families have with them. So now coming to the topic, which is to do with autonomic function. This is a slide which is quite difficult and busy to read. I've just taken it off the internet. On the left-hand side, it is to talk about the autonomic function is created by, there are two parts of it, the sympathetic activity and the parasympathetic activity. Sympathetic activity, in a nutshell, increases your heart rate. It reduces the motility of your gut. And it produces more stress. So stress-related aspects of thing is the sympathetic part. Parasympathetic is usually for relaxation and your gut in terms of digestion. So, and in terms of the bladder, so I'll just go about it in a little bit more detail. So, and in terms of how does this happen, how does the control get affected? It could be because of brainstem immaturity. So it could be to do with the central hub, which actually controls the autonomic function, is closely related to the brainstem. So if it's immature, as is the case often in Rett syndrome, it becomes disrupted, and so therefore, especially cardiorespiratory issues can occur. And then, of course, it comes to what are the neurochemicals that control it as such. And there are many things being spoken of, whether it's serotonin, norepinephrine, substance P, leptin, all sorts of things. But ultimately, it's at an individual level, we have to understand what works and how can we get control. So going to the variables, there are certain principles of using the variables. The variables that we use collect data on three-dimensional movement, surface temperature, heart rate variability, and also electrodermal activity or how much you sweat. So you can only my view has been that collect data using variables only if you can interpret it properly. Otherwise, you can actually have more problems with it, because artifact detection is very, very important, and how you manage the artifacts. And I think it's one of the things that affected the first clinical trial in Rett syndrome ever done in the UK, where the primary outcome measure was actually a biomarker, and the biomarker didn't show a difference. So it's a very important aspect to be considered. If the sensors are, you have various kinds of variables that are possible. You can have chest bands, you can have wristbands, you can have rings, all sorts of things. But in terms of, if you're using a chest band, you need to remember that kyphoscoliosis will have an impact in terms of how the sensors sit and how the data is collected and how it is interpreted. And then, of course, if it's worn on the wrist, you have to interpret it based on movement and how can you manage the artifacts, how do you remove it, and I'll show you as we go along. And in terms of where the sensor sits has an impact in terms of whether you're putting it on your wrist, on your ankle. The electrodermal activity is completely different in these two areas. So how you interpret the data depends on where the sensor sits as well. So if you're looking at autonomic manifestations in Rett syndrome, you've got the emotional and behavioral aspects, which is from anxiety, panic, low mood, agitation, all of those aspects of it. You've got breathing abnormalities, where especially daytime breathing abnormalities, hyperventilation, breath holding, apneas, all of that, shallow breathing. Cardiac things like you can end up with long QT and so on, the risk of sudden death. In terms of gastrointestinal, you've got constipation, gastroesophageal reflux, abdominal bloating, and of course then you've got thermoregulatory aspects, which is to do with cold extremities and temperature instability. And temperature instability is a very important aspect, which I think we have not given it as much importance, especially now that there are transformative therapies being started. The reason is that if you've got a complication, if someone's got early signs of sepsis, one of the things that will be looked at when you go into the hospital, if you take a child into A&E, is the temperature. And if the baseline temperature of the child has always been slightly lower than what would be considered neurotypically in other individuals, the clinician in the A&E or the other doctors may not take that into account. And so what then happens is that the temperature is still considered to be within normal limits, and therefore it's not viewed as a fever, which then means that you do not get the trigger for the full workup for sepsis. And so therefore, one of the things that we've ended up training families to do if they're in a crisis, is if their child's baseline temperature is lower, that they have to mention it when they go in there, so that it's not there. If their baseline temperature is roughly 1 degree lower, then that has to be clearly stated. Otherwise, important medical information can be missed because that is not taken into account. So, and that's partly to do with the thermoregulatory issues, and there's a central thermoregulation that may not be functional in this condition. So, if you're looking at heart rate variability, basically it's variation in time between heartbeats. That's what it means. You've got a parasympathetic and a sympathetic control in terms of how it manages it. So if you've got high heart rate variability, it actually indicates good health. It basically means that your heart is able to beat as needed depending on the need of things around you. If there's something which is a danger, you can change. If you need something, it can adapt appropriately. When you've got low heart rate variability, what it means is that it's less able to adapt, so it's more rigid, and so therefore you end up having an increased risk. Also, there's impaired regulation. There's an increased risk of stress, increased risk of problems. And so in other words, when it comes to sympathetic activity, you end up with increased heart rate. Parasympathetic, it decreases heart rate, and it increases the heart rate variability. When it comes to the clinical interpretation, it just means that high heart rate variability is what you're really looking for. What have we found in Rett syndrome per se? It's when you compare day and night, in Rett patients, we found that there's lower heart rate variability during the night compared to what you'd expect. Now, this means that it suggests reduced autonomic adaptability during the night. And this, again, is something that has to be focused on, and we have to look at what it implies and whether that has any health implications. And of course, the other thing is that heart rate variability changes occur with age. And in older individuals with Rett syndrome, what has happened is heart rate variability has been lower. Again, it could be just a normal process. However, these are indications to actually start exploring those individuals with these kind of factors, how can we try and see whether it has implications in the longer term and what can we do about it? So if we're looking at, and there's another aspect of it which we have, I think in general, when you look at literature, advice and so on, the vasomotor aspects of function has not been given the level of importance that is needed. So there is actually autonomic vascular dysregulation that can occur in Rett syndrome. And it basically is a loss of autonomic balance, which is, so there's reduced heart rate variability. But there is also the sympathetic tone can be fluctuating. So you can end up having episodic vasoconstriction and vasodilatation. And so clinically you can manifest with cold feet and hands and feet. Color changes, mottling can occur. And of course, orthostatic hypotension and blood pressure instability. And these all aspects are relevant when it comes to the quality of life of an individual as we move along. Thermoregulation. It's predominantly a sympathetic activity, and it's through some of the fibers which link up with the cholinergic aspects. They stimulate the sweat glands, and then you end up having, you can end up with evaporation leading to reduction of temperature, and also in terms of vasodilatation. But vasoconstriction and then goosebumps and so on, those are the things that actually help you to conserve heat. When it comes to central thermoregulation, it's the hypothalamus, and it's the preoptic area that actually controls that. And that aspect of it is what I was talking about. And there's enough information to suggest that central thermoregulation is something that needs to be looked at in greater detail. And this is not just in Rett syndrome. There's a whole debate about whether one should be looking at that even in autism as such. So when it comes to the autonomic control and peripheral vascular and thermoregulation aspects as such, normal autonomic system function means that you have a sympathetic mediated impact, which is normal. But in Rett patients, it's dysregulated and cause extreme discoloration can happen. The bit which I think is important is that the sweating can also be affected, and you can have either too much or too little. And again, that's one of the things that the electrodermal activity can pick up whilst the watch is being worn. So in all of these areas, I'm not going into details about it. It's the same thing being reiterated. You can have vasodilatation, sweating, temperature changes, and heart rate variability that can be affected. When it comes to gastrointestinal, it's important to understand what parasympathetic activity can do. It increases secretions, it increases gut motility, and it increases blood flow to the gut, and it increases sphincter relaxation. Now, it's the opposite that sympathetic activity does. So one of the issues that has started to be discussed now is that rather than just looking at it as a gastrointestinal problem, yes, it's a gastrointestinal problem, but what is the autonomic component that is actually contributing to the gastrointestinal problem, and to see whether to do studies to look at whether using autonomic normalization, dysregulation being controlled, would that actually change how gastrointestinal symptoms are being experienced by families. This is a figure from a publication that Dr. Singh and myself had published some time back. It's to talk about when behavioral dysregulation, autonomic dysregulation, and emotional dysregulation all come together, and then that's the time when we actually call it as EBAD. However, you can end up with stress, physical symptoms, puberty changing as you grow older. These levels change. The EBAD can manifest differently as one grows older. So the issue is that EBAD is actually quite easy to measure in terms of symptoms, And I think it increasingly should be considered at least as an outcome measure in clinical trials to see whether it's making a difference in it or not. Again, this is a paper which Dr. Singh led on, and it was looking at sudden deaths were, in terms of autonomic dysfunction and sudden death, and then across the across children, and then understanding how we could extrapolate it to Rett syndrome itself. And basically, the finding was that when it comes to, there is a brainstem vulnerability in Rett syndrome, they've got cardiorespiratory issues. So when you have a propensity to increased QTC, and also you've got breath holding, when you breath hold as such, your QTC changes. It can get prolonged further. And then if you have a seizure that spreads to the brainstem, so at that point in time, the sort of multiple levels of problems can lead to an arrhythmia, which can then be fatal in some individuals. So the same thing the risk cascade for sudden death would be uncontrolled seizures that spread, the brainstem especially, medications that reduce the cardiorespiratory drive or increase the QTC, and especially reducing the cardiorespiratory drive is when people are on very high doses of benzodiazepines, which prevent you from actually being able to have the cardiorespiratory burst that's needed for survival. And where if you end up with sepsis and infections, then of course what happens is that you end up with severe breath holding, and then that can then lead to the combination of all of this would lead to long QT tachyarrhythmias and sudden death. So that's really what the review suggested. And there's another team who have presented much the same thing to suggest that autonomic dysregulation and sudden death in Rett syndrome is using exactly the same thing as such what I've just mentioned. You have multiple levels of problems. When they all come together at the same time, that's when you can end up having sudden death. And that's seizures and infection, sepsis. That's really where the problems lie. So far I've mentioned things about Rett syndrome and autonomic function, and now I've got a few slides to talk about what our findings from the CIPP Centre itself is. So first of all, we developed this particular questionnaire called the Multi-System Profile of Symptom Scale. The MPSS has now been accepted as one of the questionnaires that could actually be used in clinical trials. The publication recently, which listed all the validated scales that could be used in clinical trials, this is one of the scales that actually scored highest in terms of the qualities that are needed to be able to be used in trials. What is unique about the scale is that it actually has system by system questions, so that is mental health, autonomic, cardiac, and so on. So therefore you can actually get the profile of the patient across systems from baseline and as we go along in time. And from that scale, we can actually get and extract an EBAD score, or emotional behavioral autonomic dysregulation score. And with that, we've actually shown that the Cronbach's alpha is greater than 0.8. So therefore, that allows us to actually use the same questionnaire, but actually regroup question items in a different way that allows us to then measure EBAD across time. So this is just giving you an idea in terms of the kinds of patients at the average of the MPSS subscales for mental health problems. So there seems to be a lot of discussion. Lots of patients have fears, panic attacks being reported, some self-injury and screaming and so on. This is the profile across the subscales. So on the left-hand side, what you can see is these are the subscales that we ask information in the last month, and the right-hand side is the last 6 months, and specifically because they are to do with skeletal problems, endocrine changes, and so on. So the issues around the kinds of problems that we are able to assist with are sleep problems, the mental health issues, some of the autonomic problems, and so on, and identifying high-risk patients with cardiac risk, which then, and the rest of it is we are trying to assist in terms of coordinating care. So out of 150 patients seen in the clinic, what we did is we looked at those who scored either we've just reclassified them as green, amber, red. Green being that's normal and nothing needs to be done, and red being their scores are high and something needs to be done about it clinically. And in terms of out of 150 patients, around 30 patients would have high mental health need. If you added the amber and the red together, we're talking about roughly 50% of patients have problems in mental health. In terms of it's across the board, where it depends on slight changes in numbers, but ultimately it's roughly 50 to 60% of patients have problems that require medical attention across the board. And in terms of certain symptoms like immune problems and so on, there were a few, but they seem to have symptoms which are quite significant. As Dr. Lumsden said, if you actually just monitored patients across time, you will see that changes occur. And so we need to know what is arising just as a consequence of time and development, as opposed to an intervention. And this is something that is relevant, because in any clinical trial, we need to take into account what would have happened without the drug. And especially if you're going on to transformative trials, if you do not have a placebo arm, then you need to have a mechanism by which you can actually understand how to extrapolate what may have happened in some individuals without the intervention. This is just to talk about breathing difficulties specifically. This was a questionnaire which asked specifically, if you had a breathing difficulty, let's say hyperventilation or apnea or whatever, how does that affect other aspects of the care? So for example, it seemed to show that dystonia got worse when they were breath holding. They were unable to feed during that time. So therefore, breathing difficulties may not just be to do with breathing that it has an impact. It has secondary impact because of how breathing difficulties affect other aspects of their lives too. This is to do with, very specifically to do with irregular breathing, and it seems to be a symptom that families are quite worried about, because they are afraid the child's suddenly going to stop breathing and die. And so it has significant psychological impact in terms of the family itself and stress. And as you can see, roughly 50% of the patients, of the families were quite stressed and worried about it if you had irregular breathing. To the point that I remember a couple of patients whom after treatment, their symptoms got better, and they no longer were having the irregular breathing or the sounds of abnormal breathing. And the parents were constantly going back to check whether the child was alive, because they had just got so used to the sounds of irregular breathing. And so even though it was better, so it just gives you an understanding as to how it affects families too. These are the kind of things with interventions in the clinic. These are to talk about, the way to understand this is on the second last column is the total number of patients with those symptoms, and basically with the interventions that have been provided, how many improved, how many that didn't change, and how many got worse. And to be honest, it appears like 50% of patients improve once interventions are introduced for the various symptoms of autonomic function. This was a paper which we published looking at wearable data to differentiate between ASD and patients with Rett syndrome, and using the biomarkers of, especially in terms of the heart rate variability and the accelerometer data and the electrodermal activity, we demonstrated that the algorithm could almost 100% differentiate between the two types of patients. In terms of heart rate variability, it has evolved over time. the norms available in the general population has also been creeping up. So as we've got more data and we've got more norms, we've changed our algorithms to incorporate the norms as such. This is one of the first papers that we published, which had data, which we developed data on Rett specific, on patients with Rett syndrome specifically. And the way to read this is on the x-axis is the age. So the patients who are the youngest are on the left-hand side and the oldest on the right-hand side. And so the blue dots are data during the day. The red dots are data from the nighttime. And so the first thing is just mean heart rate. And what you can see is that the mean heart rate is much different from the normal population. And the dotted line, I'm not sure whether it is visible or not, because on my screen it seems okay, but I'm not sure there. The dotted line is what would be expected in typically developing individuals. And so what you can see is that whether it's the heart rate, mean heart rate, various level things like SDNN, which is a matter of sympathetic activity, and so on, all of these are just to show you that in Rett population, they are very different compared to the general population in a general population out there. And this is across the age range. And so what we've done is we've developed fun plots to show what could be the level of change that you can expect in a child with Rett syndrome if you had an intervention which was targeting autonomic function. This gives you an indication. What we did was we analyzed the data of 58 patients and using a cluster approach, what we found across the age range, what is very clear is that the green is the under 10-year-olds, the green line, and the blue is between 10 and 19, and the red is greater than 19 or 20 years old. And what you can see is that as you grow older, your mean heart rate is reduced. The changes are the peaks in between, that is when you're awake, and the dips are when you're asleep. And so this is a 48-hour rhythm. The same thing is highlighted across the age range in different measures, and that was the heart rate that I showed first, and these are 4 different measures of our heart rate variability, all showing the same thing. And as would be expected, motor activity was much higher in the under 10-year-olds. It indicates that motor activity is gradually reducing as you grow older because of disability. This is using the variables, we can actually identify sleep and activity, and that's quite clear. This is as time has gone on, we've based on more data coming in about normative values of autonomic function using variables. We've now been in a position to start presenting data like this, where unfortunately I'm not able to think. If you just focus on the first band, that's activity levels. And where what we've done is we've coded it as inactive for blue, green is light activity, moderate activity is amber, and severe or vigorous activity is red. That's the first thing. And what you can see is that this particular child is even during sleep, it's interrupted because there is the patient's sleep is interrupted because the patient's waking up. The second band is basically to do with the heart rate itself. And this you'll see quite a lot of gray bands, which is these are the parts of the data that we had to remove because of artifacts, because of stereotypic movements. And so if you don't do this, you will end up with the wrong data analysis and thinking that something is happening which is wrong. So we've now developed AI-based abilities to actually look at excluding data which is arising in the context of sensor-based problems within the heart rate sensor. And the third line is actually the electrodermal activity. And electrodermal activity in this particular patient, you can see there's multiple points at night where there are problems happening, which shows that there's some autonomic dysregulation occurring. So the same thing, this is a patient who, this was the reading in 2021, and it shows that there is increased activity in the motor activity in areas, and that is usually to do with stereotypic movements. And then the second band shows that there was heart rate being high, both during the day and night. And the third was that there was increased electrodermal activity. And all I wanted to show is that after treatment, what you can now see is that the motor activity is more normal, and the heart rate, however, the heart rate has not changed. But what has changed is the electrodermal activity has decreased quite significantly. So there are aspects of electrodermal activity that may actually be indicating stress, and we need to understand more as time goes on. And what we have is we have all of these measures now collected for every patient, and we are focusing on trying to see how we can actually use the data to predict those at greatest risk for cardiorespiratory complications. So this is what you would ideally want, as well as happen in one of the patients, where in the green bands is what you want the heart rate to be, and this is the heart rate demonstrating that the patient has actually the heart rate is now normalized to what you would want it to be, and it was very severely different and abnormal before. So this is just to finish the talk, saying that we now have got the, using the AI methods, we've ended up identifying that there are 3 groups of patients, and the 3 clusters. And basically the one with green is the green line is the healthy, what you want it to be, and the red is where things are not what you want to be. And this is the data showing various aspects of heart rate variability. And what I just want you to look at is if you look at the red dots and line, you can see that in terms of the first graph on the top is where you've got greater heart rate, and then after, whether it is during the day or when you're asleep, it's high, heart rate is high. But when you're looking at the other measures like PNN50, it's very low, and that indicates low heart rate variability. The same thing is there in the SDNN and RMSSD as well. And so what this shows is that this particular group who is in the red cluster is the group that we have to focus on to check and see whether we can identify anything that we need to do to try and get them out of the red into the amber. And that's the same thing which is being shown in a different way. But I also want to highlight, this is not to do with Rett syndrome. This slide is not data from Rett syndrome. This is data from the rest of the children in my clinic. And what it shows is identical problems. That is to do with the fact that you've got these 3 groups. That is to do with one who is normal, with parasympathetic activity being normal, another where you have in between, and a third where it's the higher risk, which is the sympathetic overactivity group. So what I'm trying to highlight is that it may not just be to do with Rett syndrome. What we're really dealing with is understanding how can we manage this high-risk group at the bottom in the red, irrespective of diagnosis, and coming up with strategies as to how to manage that to prevent complications. This is a study which we published looking at buspirone and sertraline, showing that it made some difference in various measures of heart rate variability. This is another study that is in the process of being submitted, showing that buspirone roughly improves cardiorespiratory function, especially in terms of autonomic variables. If in a nutshell, to summarize, when it comes to intervention in autonomic dysfunction, you've got pharmacological approaches, fundamentally using beta blockers for cardiac symptoms, anticonvulsants if it's seizure related and seizure control needs to be dealt with. Emerging therapies like 5-HT1A, partial agonists or agonists need to be looked at. And then you've got all the other things which have to be done in order to get optimal outcomes. And that's basically respiratory support, advise about respiratory function and how to deal with it, and in terms of physical therapies, and most important, in terms of collaboration amongst clinicians and amongst specialties in order to be able to provide a holistic approach to care. This slide I've just put in because there's transformative therapies that are constantly in everyone's mind, but it looks like EBAD is something that needs to be explored further in those going into trials for transformative therapies, because you need, if someone is unable to stick to the trial, all of the intricacies that are needed and the significant demands of the trial, it's actually going to be detrimental to the patient as well as the trial itself. So there needs to be some sort of understanding about EBAD, and especially understanding how treatments like immunosuppression, which is essential for transformative therapies, how it impacts emotional behavioral outcomes, and especially it's very common for prednisolone to produce depression in children. If that is missed and it's then viewed as being an outcome that's negative in the trial, that's actually an issue to be considered. This is the last slide, which is I think somewhere the last slide is to do with what we used to focus on, trying to develop digital passports, where we could have the events being documented, having the clear details about what happens with the watch data and so on in real time. However, this requires quite a lot of effort, and it's at the moment it's been paused in the clinic because we've ended up losing the person who was doing the thing, but we are in the process of looking for funds to continue with it. Research gaps, I think longitudinal studies are essential, standardized tools, and of course exploration in terms of trials. To conclude, I think EBAD and autonomic dysfunction is common in Rett syndrome. Effective measurement is available currently in terms of questionnaire and wearables data. Interventions need to be focused, and we need to actually look to see whether it makes a difference in clinical trials. And I think transformative therapies should consider management of EBAD prior to entry into trials. This is the team. Dr. Singh, who's going to be speaking next, is a senior lecturer in the team, and Dr. Ramchandran is the other psychiatrist in the team. Dr. Kitty Kwan is the consultant psychologist in the team. Dr. Federico Fiori, he is the data scientist and leads the data science team. Dr. Samia Chisti, she's a specialist doctor in Rett syndrome. And Shashidhar and Abel, they are other data scientists in the team. Leighton is the research manager and coordinator at the moment. Georgina and Athena are other researchers in the team, and Rosie, who has been coordinating the Rett Centre when she's resigned recently. Thank you very much.